I'm Dr. Bradley Van Heukelum. I am the medical director at his branch's Community Health Center. I also am on faculty at University of Rochester. And I have been working integrating primary care and mental health basically since I graduated my fellowship in 2010. Various different models, and I'm very excited to present with my colleagues here our collaborative care model, which from my experience has been the most effective and led to the kind of best sustainability as well as outcomes. So, which is what we care about most. So, I'm going to let them introduce themselves. So, Rebecca goes first.
Hi, good morning, everybody. My name is Rebecca. I am the director of behavioral health here at his branches. I don't know if you're familiar with the area a little bit, but I'm actually from Buffalo, and they brought me on into Rochester, and it's been great. It's kind of been a passion project of mine for the last 4 years. So I'm excited to kind of share with you how that's been for us. So thanks for having us.
Awesome. And I'm Mike Weston. I'm executive director of his branch's Community Health Center. I've been at his branches since 2019, executive director since 2021. And this is just a reminder, always be careful of who your friends are because they may bring you into healthcare and make you jump in and do something you've never done before. So
Definitely my fault. Awesome. Good. So just if you have questions, just kind of write them down. We will have a pretty significant question and answer time at the end. So we're just going to try and get through stuff and then get to questions at the end. We're going to start off with just some Rochester trivia. Okay, most people don't know Rochester very much. So first question is, what's Rochester's most famous food? Raise your hand. Any ideas? Not pizza.
That's
no.
Buffalo.
Nope.
that's a good guess.
We have someone from Buffalo over here, so I don't think you should be able to answer. Anyone else? No?
You need to do
No?
hoagie. That's a good.
Close. All right.
Okay.
All right.
Okay.
Okay, it's called the garbage plate. Garbage plate is a combination of mac salad, home fries, topped with a meat sauce, hamburgers, hot dogs, onions, and a whole bunch of different flavors. And there's everybody has their favorite garbage plate place. My favorite's the one up here called Dogtown, but you can get it at the Genesee Brew House. And everyone has a little bit different kind of spices. So a garbage plate. So if y'all ever in Rochester, you got to get a garbage plate. I know it sounds gross. It's actually quite delicious. And it's an experience, most of all.
Very healthy.
Very healthy. So,
All food groups.
all right, very good. We should give our treat out to this young lady up here because she ventured a guess.
That's good.
All right. Okay. Second, who's the most famous person to ever live in Rochester? There's actually two potential answers to this one. Super, super famous. Any ideas?
Our history books have failed us.
They have failed us. Okay. Frederick Douglass and Susan B. Anthony are both from Rochester. So this is a park right next to the Susan B. Anthony House, which is a museum at this point in honor of her work in the suffrage movement. And Frederick Douglass lived and wrote most of his works that you read today in Rochester. So, okay, final thing is we're called the Flower City, despite living in the north. What's our most famous flower? What are we known for?
At this point, you could just guess the flower. First time?
I would too.
Okay.
Yeah, lilac. Lilac, yeah. So we have a whole park that was designed by the same guy who designed Central Park, Dr. Olmsted.
Frederick Olmsted.
And it is littered with tons of lilacs. We have a lilac festival, which is a whole week-long, actually I think it's 10-day long festival in May. And we have a lot of festivals, but this is definitely the best one. So beautiful. This is just one variety. There's hundreds and hundreds of varieties of lilacs which have been developed in Rochester. So just little icebreaker there. So thanks for playing. All right, we're going to move on.
Yeah, and with a place that's as beautiful as Rochester is, there's a lot of resources within our community. There's also a significant need. So that's what we're going to talk about today is the need in the city of Rochester. So Brianna Lathrop, who's around here this week, has a comment. She says, a person's zip code matters more than your genetic code in determining whether you live or die. And that's certainly true within Monroe County, the county that Rochester is located in. Monroe County has 750,000 individuals. Those who live within the city of Rochester, specifically the black community, dies nearly a decade earlier than those who live in the white suburban areas of the community. So within a 2-mile distance, there's a gap of almost 10 years of life expectancy. So our clinic is focused on those who live within the city of Rochester in order to close that gap. So for those who are living in that city, toxic stress and poverty is kind of the key identifier. So as we go through collaborative care today, this is what we're really speaking to. So housing insecurity, food insecurity, racism, trauma, these are the type of complex issues that we're dealing with. Rebecca and her team works with on a regular basis. So focus on mental and primary health outcomes are the result of toxic stress in Rochester. And so kind of what does that look like in our city as a whole? For the 750,000 individuals, 12% of our population has significant mental health problems, which is 14 days or more of poor mental health. So a little more than 10%. And more than 50% deal with mental and emotional health issues on a basically almost a regular basis. So that's what we're working with as far as our city is concerned. And as a clinic, we often talk about that our best opportunity is where our community and injustice overlap. And so that's where our mission comes in. And so that's what Rebecca's going to talk about next with our specific patient population.
Yes. So when we look at the folks that we're serving in our clinic, we are showing that those of them over the age of 12, 30% of them are showing a mental health diagnosis, which, as you can tell, is quite higher than that 12% we were showing earlier on that slide. So not only is this a national need or a community need, but it's also something that we are noticing directly within our clinic. Here's a quick snapshot of the folks that we are serving, age 12 and over, who are carrying a diagnosis. 17% with depression, 22% with anxiety, 2% with PTSD, 2% bipolar, and then there's other diagnoses. What I'd like to a caveat to this slide, though, is these are only the folks that are carrying a diagnosis. We know in our work with these folks that these numbers are actually much higher. But if we are looking at statistics, these are those that are diagnosed. So there's a pretty high percentage of folks that we're looking to support within our community, within our clinic, and there's definitely a need out there.
All right, so the key and the reason why we're presenting today is because we feel like the model that we're using at his branches over the past 4 years has been very effective. I've been working in integrating primary care and mental health. Even when I was a resident, my residency was known for that. We had a mental health program. So I've been intimately involved with that work in Rochester throughout the years. So I've come up with just a couple standard models that I would say that I've seen, and we're going to go through them really quickly. So first is just your traditional referral model. Doctor diagnoses them with depression or anxiety or PTSD. They put in the referral in their system. That referral goes to a separate clinic. That clinic then has to reach out to that patient, get them to an appointment. They have to get their own way there. They have to actually show up. And, the provider, it may or may not happen, right? So I feel like this is the worst model. And it might work for if I'm sending someone for they have leukemia or something like that. But for mental health in particular, there's some pretty significant stigma associated with it and some barriers, particularly in the patients that we care for, that make it very, very difficult. I'm not going to read down through all those, but you guys can look those up. Okay, the second model is kind of in between, where you have not someone who's trained in mental health, but is a caseworker or a care manager who just kind of acts as a navigator between the primary care setting and the specialty groups. And so we do this a lot for other reasons, but in mental health, this is a couple things that I think are pretty important as to why this isn't the greatest model. Is one, you have to have providers who are really comfortable with mental health, and not all family doctors are, although increasingly, hopefully the training that our medical students are getting and the training through their career is kind of pushing us to do that. I've seen that increase over my career. It's probably up to close to 40% of what I do is mental health kind of alone, right? and 60% is my traditional like medical problems. The advantage to this is you can have anybody do this, right? You just have to have someone who knows the system and can help connect people and get them kind of break down those barriers. The third model, I'd call this the like ideal model. So at University of Rochester, we did a program where we had in my clinic a licensed clinical social worker who could do psychotherapy. She could also do on the fly, in the moment, suicide assessments, get people to partial hospitalizations. So I would identify something, I'd call up my friend Jen, I say, Jen, I need you to come into room 2, and I would just pass it off to Jen. It was a beautiful thing, and she did a great job. And then we had a rotating psychiatrist who would come in and do medication consults. And through that, I learned quite a bit from how to prescribe medications and how to handle those situations. The problem is you need really highly specialized people. So while it's ideal, recruitment and retention, we've had now an opening for that therapist now at my office for 7 years, okay? Because everyone who gets to that level of education doesn't want to be in a primary care setting. They want to go into private practice. And so while it's awesome and fantastic, it's not sustainable. And so that's where we feel like the collaborative care model kind of balances out that and leads to our best outcomes. And I'm not the expert at collaborative care. Rebecca's actually the expert. And this has been, like she said, her passion project for the past 4 years. So I'm going to let her take the stage.
Thank you. So yes, I definitely will disagree respectfully in the expert piece. When I was brought on 4 years ago, this idea was fascinating to me. But we kind of said, hey, let's see what we can do. Let's see what this looks like. So we have found that this has been extremely effective, particularly for the folks that our clinic is serving. What that looks like is there are three team members that really work collaboratively together. The primary care doctor, the behavioral health care manager, as well as a psychiatric consultant. And they all have very specific roles, but also very important roles. So our primary care providers, such as Dr. Brad, they are usually those first line of communication with our patients who are identifying a mental health need, or folks like Dr. Brad are able to identify that for them. And there's that trust. There's a relationship with most primary care doctors and their patients. So this is the great initial contact. Our primary care doctors, they're the folks here that are going to be prescribing those medications for us. So it's extremely an important role right there. And then the next part is our behavioral health care manager, working right in that clinic. That care manager is kind of that liaison between the psychiatrist, the primary care doctor. The behavioral health care manager is also going to be the one that's going to be that lead contact for the patient when it comes to assessing and treating and referring for their mental health needs. It's the primary or the behavioral health care manager. They're going to be coordinating the care. They're going to be sharing some I'll get to this in a moment, but some psychotherapy techniques, supporting the medication management, also alerting the primary care doctor to any updates, any safety needs, medication concerns, such as that. We're able in that role to offer some brief counseling, things that are going to be evidence-based. That's really going to be the focus behind the services that a behavioral health care manager is going to provide. What it's not is traditional psychotherapy, but what it is, those brief counseling sessions, they can consist of brief counseling, things like evidence-based things such as motivational interviewing, behavioral activation, problem-solving techniques such as that. Very extremely goal-oriented, behavioral task-oriented. So that's kind of that role so far with the behavioral health care manager. And that third piece of the team is our psychiatric consultant. Could be a psychiatrist, could be a psych NP, but that person, their role is also unique and significant. Although they are not seeing the patients themselves, they're going to be working with the behavioral health care manager very directly. We're going to be consulting with them on a weekly basis. going to assist the behavioral health care manager if there are folks that are not doing well in treatment. Maybe they're not improving. So it can assist with techniques, could assist with medication recommendations, management, can support the primary care provider in making some of those medication decisions if the primary care provider does have questions. So that's the important role of the psychiatric consultant. Oh, yes, I'm sorry. So you have two members of the team here today. You've got our primary care provider, and then you have myself, who was in that role of behavioral health care manager for a few years. We don't have our psychiatric consultant with us today, but he did provide us with a video to share with you. Just about 3 minutes.
My name is Dr. George Nasra. I'm a professor of clinical psychiatry at the University of Rochester Medical Center. I've had the privilege of working for the last several years now with his branch's Community Health Center in support of their collaborative care program. This is a team-based approach, so every person on the team has a key role to play. My role as the psychiatric consultant is to be available to the behavioral health care management team and to the primary care providers. On a weekly basis, I meet with Rebecca and Mirali, the two behavioral health care managers on the team, and we go over different cases, patients who are new to the program, patients who are challenging to them, to the primary care providers. We review their progress, reconsider their diagnosis, even make medication recommendations, which in turn they will take to the primary care providers for implementation. During those weekly meetings, we also review the PHQ-9 scores and G87 scores of those patients and make medication and care plan adjustments as necessary. Beyond those weekly meetings, I'm also available to the primary care providers throughout the week. They call me with questions about medication side effects, adjustment in different medications, augmentation, questions that they may have, and this augments my role and make it more valuable to the practice as a whole. This model of behavioral health or mental health integration in primary care is especially valuable in a practice such as his branches being in FQHC, given that many of the patients have challenges in terms of their health-related social needs, whether being access to affordable health insurance, transportation needs, food insecurity, or housing insecurity. Patients find this model of care really valuable. They like the fact that they are able to get their mental health needs met at their doctor's office, where they have developed a trusting relationship. Primary care doctors also find that this model of care is valuable to them. They like the ability to manage patients more efficiently. They have more confidence in being able to treat depression and anxiety and stress disorders with the collaboration of the behavioral health care managers and having access to a psychiatric consultant when needed. I've truly enjoyed this collaboration with his branches. Patients are getting the care that they need, where they need it. They are showing improvement in care, and it's been a privilege to be part of this team.
So although all of the different models of behavioral health have its benefits, we have found over the last 4 years that this particular model has been extremely sustainable for both our facility as well as for our patients that we are serving. It has been extremely helpful because what I've seen is having this service right in-house really helps with that immediate connection, whether it's an immediate risk assessment that needs to be done or it's not losing folks to the referral process. How many of us have patients who are given a referral and a recommendation to link and they walk out the door and that follow-through isn't always there? Having this in-house and that warm handoff oftentimes have really been shown to really link more patients. So it's been extremely helpful. There's a couple requirements for this program that we want to to keep an eye on. The registries that we're referring to here on this slide, this is something that is a requirement of the program. There's some specific registries that we can sign up for. We particularly use something called CMTS, and that registry helps keep track of the measurable outcomes that we need in order to submit for billing. So, for example, the PHQ-9s and the GAD-7s, those are required on a monthly basis. Those are things that need to be placed in the registry. That's one of the reasons why this program right now is for ages 12 and older. Those type of things, such as the GAD-7, PHQ-9, are only available to 12 and older. And also, eligible diagnosis is important when we think of this program. This is not for someone who is diagnosed with a significant mental health disorder. We are the eligible disorders for this program include the depression disorders, anxiety and panic disorders, PMDD, other things that are complicated by pregnancy, acute stress reaction, PTSD, suicidal ideations, and self-harm. Those are the diagnoses that are billable under this model. So we know that there are many other diagnoses out there, of course, but because this is not traditional psychotherapy, we are a little bit limited on the type of diagnosis that we use under here. But this gets us started, right? This gets us in the position where we can work with these folks and make sure that they get to the services that they do need. Billing always comes up. Why this is sustainable for us is there are a lot of ways that we can reach these patients under this model. Minimum monthly minutes is is our target in order to bill for it. So we can bill per patient per month. So it's not a fee for service. We're not billing them every time we have an interaction with these folks. So, for example, the initial month, we need 70 minutes. Months after that, 30 minutes. But what is really unique about this program is there's several ways to get those minutes in. It can be in office, it can be through video, but it can also include phone call follow-ups as well. Those minutes also include the time that the behavioral health care manager is consulting with the primary care doctor. Those minutes can also include our documentation time. So those are some ways that make it very sustainable for the staff involved in this program. And again, I had mentioned the PHQ-9 and GAD-7. That's that measurable outcome that they require. That's what the standard is that we're using right now. I had mentioned a lot of those things already. Thanks, Mike.
Always on time.
So for us, we have found that yes, there's benefits to all the different types of programs out there, but this has been sustainable for a lot of reasons, and we've been really happy with this over the last 4 years.
I just want to tag on just a little bit from a provider standpoint. The relief that it comes as a primary care provider when you're seeing 12, 14 patients in a session, right? You got 10 minutes, 15 minutes, maybe 20 minutes with a patient. And these mental health diagnoses just pop up. It might be at a physical, right? And you're talking about their mammogram, and then they talk about how their mom just died, right? And so it allows us to kind of assess quickly, but then also easily access adequate mental health care. It's not something like I'm saying, why don't you come back in 3 months, because that's when I'm booking out for, and we'll talk about it then, right? Because most mental health stuff is stuff that needs to be addressed with really quickly. So the ease of access. And then there's those urgent, emergent situations where you're like, I'm not perfect at doing suicide assessment or knowing when someone should go to the hospital. But boom, I bring in Rebecca or Morelli, and it's like they can step in, I can go see another patient, and then I can come on back and kind of wrap things up. So it's this kind of like seamless transition, and also the whole trust thing. Yes. So trust is such a big part of healthcare, particularly in this population that we deal with. And it's, they almost always, like, they go to a specialist, they come back and ask me if I would agree with what the specialist said. I'm like, I'm not a neurosurgeon, right? Yes, you should do what the neurosurgeon says, but they trust me, right? So that trust gets nicely transferred over to Rebecca initially, and then she builds trust over the time that she cares for them. So.
Yeah, I would absolutely agree. What we see often with, your appointments is you don't have that time to address all of these things. So
Or
to be able
skill.
to have that. Yes.
Because I don't know motivational eating very well. I don't know brief counseling, right? I'm a family doctor, right?
And the collaborative care piece has been extremely helpful. So a primary care doctor starts one of our folks on medication, and then I'm following up with them on a regular basis. Maybe they have questions, maybe they have concerns, maybe we think it needs to be increased. That communication is readily available. It's easy for me to not only talk with the psychiatrist, but the primary care doctors are right in-house with me, easy access. And that collaborative piece is really the heart of this type of model.
And it's informal. Like, we see each other every time I'm in the clinic, and we pass by each other and we say, how's so-and-so doing? And, or if she comes up and says, I think we should increase the effexor because he's not doing so well. But we also have formal meetings once a month where basically the whole team, so behavioral health team, our nursing team, other doctors and providers, we do have a case manager who steps in. So, and we talk about our most challenging patients and get ideas from the whole team at that time. It's also the time where we kind of just like lift those people up in prayer, right? We say like, these are people that we're really trying to figure out how best to care for, right? And myself is not good enough to take care of this. But as a team, we can come up with a better plan. So it's a great way. So we have formal communication and collaborative care mode, but a lot of it is just this informal kind of handoff, just walking around the clinic. And, you know, she'll call me up and say, I need to talk to you about Joe. All right, let's talk about Joe, right? So that connection is just so seamless and just allows for just excellent care.
Yeah. And it's quick too. In my previous roles, if I've had to contact one of my patient's doctors, whether it's primary or a medical doctor or a psychiatrist, it could be a really long time before I got a return phone call. And that sometimes, depending on the situation, can really be a barrier to care. So to have that built into this model, it's just been such a blessing.
Yeah, agreed.
And then as we get to start to talk a little bit about money, how do we pay for this? How do we make sure it works? One of the things I like about having the psychiatrist, Dr. Nazar, who you saw, it's nice for us to be able to pay him a contract wage instead of having him come into our office all the time where we may not be able to have that entire bill. So it's nice to be able to pay him a monthly fee for his services through contract. So that's another way that as a smaller FQHC, we're able to do that instead of having him come on staff, which we could never afford. We want to make sure that we share that with our office managers, with our counselors, and with our providers. So where do we get the money from the program? I like to think of money in a couple different ways. There's princess money, where some foundations can give you all kinds of grants and money, and it comes in one package, and it's beautiful, and it works perfectly. There's also kind of like this Frankenstein's ghoul model, where you kind of just take and add everything together. So at his branches, what we like to do is we leverage usually a mashup of finances in order to connect with community partners, foundations, grantors, insurance companies. We're able to use that to build our team, offset initial launch inefficiencies. Like once we start a program, Rebecca wasn't 100% busy right away. So we were able to say, help us launch the program, and then add that in, and then ultimately long-term sustainability. So these are some of the partners that we've worked with in order to get started. So even at the beginning of the program, we recognized during COVID, we had some opportunities to leverage some COVID grants for our specific community from the United Way, from the Community Foundation. They had grants available. We were able to take that initial investment of $50,000. We were able to create an environment for Rebecca. We remodeled our space. We built some counseling rooms for her. We stole her from some friends in Buffalo and other organizations. She gets to drive now to hang out with us a few times a week. She's able to work at home as well. So we're able to leverage that. And with the early successes, these two organizations gave us additional funding. So they saw the stories, they saw the data, they saw the impact that we were having very early, and they invested more. So then it came to 2023, Rebecca was getting full, we were running out of space, we had really begun to see an influx of Spanish-speaking patients, and so we went back to a couple of our friends through Flips, it's our regional IPA. We had an opportunity as well through our New York Senator, Summer Brook. She was able to provide us some money for justice-involved individuals. So that next round got us our next staff member who happened to be a bilingual individual. We were able to do open hours. We had walk-in sessions, as well as now we have someone who had English as well as someone who did Spanish. So that expanded additionally our staff and our opportunities. And then at the end of 2024, we really began to do like our next model, what things are happening next for us, and Brad will talk more about that, but we're establishing new programs, and right now we're finalizing purchase of a new building so that we'll be able to add additional staff. So MVP, one of our primary health payers, was able to give us an additional grant to start this program, and then we're even working with another FQHC in town, Mosaic Health, in order to provide more services for substance abuse. So we'll have a contract with them to provide services. So we've taken this model, we found money in a bunch of different areas, and we kind of combined it together to create the on-ramps, create the launch points, and then to create ultimate sustainability. But again, it's a little bit of a mishmash where we've gotten everything. And then even for us to be here today, MVP was able to provide for a service to travel down, to rent a car, to pay for our sessions. So special thanks to MVP Healthcare. So if you don't have good relationships with the insurance providers in your community, make sure you get to know them. Ask them for money. Have them come to your location. They can be some of your best friends. Even if they don't pay you enough for every visit, you can get some special deals on occasions through their grants and their programs. So build up friends with your payers.
Yeah, I think an important thing with this is the initial money is that's like startup, right, cost, because there's going to be inefficiencies. You're not going to be seeing 60 patients a month, right? But the sustainability comes in that the model does sustain itself long term, right? So when those monies go away and you ramp up to full capacity, that person pays for themselves, right? And so that's where the sustainability comes in.
And our program, I typically build grants to last between 18 months has kind of been our magic number. It's kind of like, hey, give us 18 months of an on-ramp so that we'll be ready by that time. Yeah.
Okay, the impact. So this is just the number of behavioral health visits that we've done over the past 4 years. You can see on our first year, we started around 650. And then this past year, we've gone over 2,000 visits. And that's with just 2 providers. So that's Rebecca and Morelli. So that's a lot of visits, right? That's a lot of visits that weren't happening 3 years ago, right, for our patients. Our clinic has grown, so we've had increased need, and that's where kind of some of our next steps are coming into it. We consider success when you reduce the PHQ-9 GAD-7 scores by 50% from start to finish, okay? We know that mental health is not, like an abscess where you just give them antibiotics and drain it and they get better, right? Mental health tends to be fluctuating. It's long-term. But there's ebbs and flows in that, right? To take a PHQ-9 from a 20 down to a 10 is significant improvement in that person's quality of life, ability to get back to work, deal with their other health issues, right? Because mental health is most of the time not their only health issue, right? And so what we've seen is basically that this model lowers it by about 40% of people meet that criteria in our time frame. So basically, the model is not meant to be long-term, right? So we're kind of cycling people in on a regular basis, right? And so Rebecca hasn't been dealing with the same people for 4 years, right? That's not the model. The model is really a 9 to 12-month model, right? Get them in, stabilize them. If you can kind of get them to a better place, great. And they might bounce back into the model if something else comes up. But at about 9 to 12 months, they either graduate, right, from our program, like they're better, or we've identified that they need more significant mental health needs. But we've also bought time to kind of get them actually connected. And so that's where Rebecca and Morelli do a great job at connecting people with like partial hospitalization, our bigger mental health providers in the area. And so that's kind of the goal of this. It's somewhat rapid when it comes to this, but it's not meant to be kind of long-term, which is also kind of builds into it the sustainability aspect. And I think financially, you're only allowed to bill collaborative care for a year, right?
Yeah, after the 12-month period, the reimbursement rate drops a little bit. Okay. So the model itself is to be temporary. They're either improving enough to transition out, or they're going to be referred to something more long-term, like Dr. Brad had said.
Yeah. And primary care stays the same, right? So like my involvement with my patients is they're not like kicked out of the clinic. It's just the behavioral health aspect gets moved on. Okay, so some next steps. So our first next step that we've done is Rebecca was able to get some training over the past 4 years from Dr. Nazra, supervised counseling. So now she has her LCSW.
Clinical, yes.
C?
Yep, C.
Yeah, C. which allows her to do psychotherapy. So she has transitioned from this behavioral health care manager role to a psychotherapist in our office, which reduces the number of like total people that she impacts, right? But it's at a much deeper level, okay? So that already like expands the access to mental health care. And because of that, we're then looking for a third partner in this to become that behavioral health care manager. The degrees that are needed, I think, is also a big thing. So one of the issues that came up in my previous models was they needed a too high of a degree, and there's just the pool of available people out there to hire for this job was just so small. But for a behavioral health care manager, you need a master's, right?
Yep.
Master's in mental health, master's in social work, that level of stuff, which there's a lot bigger pool of people to kind of draw from. So that's where that sustainability, because people shift, right? And they move, and they get more education, and they move on to next level things, right? And we want people to do that, but we also want to have that like feeder program back in, so we're not kind of just like blowing out the program because we have nobody to actually do it. So that just started, so we're really excited about that. So that's our brand new experiment. So far so good, right?
Absolutely. It allows us to, from a billing standpoint, it's great because this is now becoming fee-for-service, right? So as a traditional provider, there's a little bit difference in that aspect. But more importantly, from my opinion, is that we're able to reach our patients on a level that we couldn't always meet under the collaborative care model. So we're able to kind of reach more of our folks with those higher level of needs.
Yeah. Other stuff that could be done, could be thought about. So this is for 12 and up. So thinking about the kind of the pediatric mental health care, which is on the rise right now. That's what I've seen as a primary care doctor over the past 5 to 10 years. And it's really hard, because what do you do with a 6-year-old who punches his teacher in the face, right? I don't know what to do with that. I'm a family doctor, right? So trying to leverage that in the community is something that might be a good next step. Bringing in kind of spiritual counseling chaplaincy, either from like local pastors, or if you have like we have a seminary in our neighborhood, so in our community. So bringing in people who are in their training, right, to kind of add in that kind of more spiritual aspect of stuff. And it's not that we don't do that as providers and as mental health providers. We leverage the spiritual aspect of our patients all the time, but that might be something that could be kind of next step. And the final one that it's not up there would be substance use, right? So substance use is on the rise, and so that's you just need access for those things. So that would be potentially another kind of place that you could kind of expand this. And this is our awesome team. So lots of people make his branches run, and everyone has a unique role. And I think one thing we haven't mentioned is it's the 3 people, the behavioral health care manager, the provider, and the psychiatrist. They're not the only team members, right?
Not at all.
So we got Kat down there. She's our MA who has the best relationships with our patients, right? And she provides this like level of comfortability of like a family member, right? And she just like draws people in. And you got to go talk to Dr. Brad about that. Oh, you should go talk to Rebecca about that. Brittany's our care manager up in the middle there. She is, she does a lot of stuff, like if I need a x-ray done or something like that. She helps arrange all of that.
She's also a support to my team as well. If we're looking at some of those factors such as housing and transportation
Yep.
and stuff that maybe it doesn't kind of fit under my scope of a session,
Correct.
she's able to kind of jump in with that as well.
Yep. And our front-end staff have been trained through what's called trauma-informed care. We got some grants to do some training. So it's really from start to finish, this process has kind of been built into our practice. So just wanted to point that out. Okay, enough of us talking. Questions? Anyone have any questions? Sir?
Just absolutely fascinating by your presentation. Thank you. Is this book, is there articles that capture a little bit more of what we did today together?
Yeah. I'm just going to repeat the question. He's asking, is there kind of further resources to learn about this model?
Yes, sir.
Rebecca?
Yes, so actually the University of Washington, as well as the American Psychiatric Association website has a ton of information on this specific model. A lot of more of those really good details that we didn't get in today. Those would be the two best resources, I would say. But Washington State actually.
And it started in
that.
Washington,
Yep.
right? Yeah, so it's kind of developed in Washington.
Yep.
We didn't create this, we're just implementing it. So, any other questions?
We're a nonprofit, so we're not an FQHC.
Yep.
And we are starting behavioral health. We hope to get that started this year.
Awesome.
And so we have a lot of people interested in supporting us from the personnel side. But we don't really know really the first thing about really starting this whole program, other than we need people and we need money. But what would
People and money.
things that we should focus on as we look to build a behavioral health program? Let's just say the money is there.
Yeah.
We just want to make sure we don't fall into any pitfalls
Sure.
as we begin our planning and opening doors.
Yeah, so the question is, if you're thinking about starting something like this, obviously money and people, providers are kind of the top two things, but like what are some other things? I think probably Mike could probably speak to that the
Yeah,
best.
I'm going to start with this, and then Rebecca, you can take over.
Okay.
So the first thing I would say is whoever is running the program is the most important person, not from the CEO perspective, but when we interviewed multiple people for the first position, if we hired someone who was not entrepreneurial, someone who is not curious, someone who is not willing to do the legwork, in our interview, I literally said, I don't have a box. And so, Rebecca, you're the person who needs to build the box. Once the box is built, then we can hire anybody else. So you need to have someone who is willing to take the thing that doesn't exist and help construct that box. If you don't have that, you'll be playing catch up from here on out. So we interviewed another person who continues to be a great friend of our organization. He can run and he can do care, but he couldn't start. And so Rebecca made the perfect sense. So the person at the front end is, first of all, most important. And then, so now you can answer the rest because you built the box.
It was scary and it was exciting and it was great. I will tell you, I tapped into my resources as much as possible. I will say, Dr. Nasra, I can't give as much enough praises. The reason why is in our local community, he has been a proponent of collaborative care for a long time. So he had done it before his branches, so I was really able to tap into him. So if you have someone in your community who has done it, make those connections, ask those questions. Those websites I mentioned before, fascinating, and they are fabulous resources. Literally, the job description for a behavioral health care manager can be taken right off of those websites. So those were really helpful too.
So first, we're a FQHC lookalike, so we actually don't get the funding that FQHCs get. That like we get the different fee-for-service stuff, but so sorry, what was your question again?
Would you change the model at all
If money wasn't involved. All right, would we change the model if the money wasn't involved? I guess I've been around this bush many times, and I feel like this is like the sweet spot, right? I loved having a full therapist in my office with a psychiatrist that I could just send my patients to, and he'd sit there for an hour and give me a list of first do this, then do this, right? But that was just not sustainable, right? So I feel like this model really balances that kind of aspect of sustainability, needs, and outcomes, right? And it also just says we're not going to be the end all for mental health at a community health level, right? So, but we can help a significant percentage of our patients, right? And we can also transition them to the people that they need. And that's primary care at its core, right? We take care of 85% of stuff right in-house, right? We don't do 100%. I don't do appendectomies, right? You need to go see my friend the surgeon for that. So same kind of idea, but I feel like this model, from everything that I've seen over my career, really balances all of those things out. Yeah.
Before we get another question, we're supposed to tell you to fill out a survey. So before our awesome student hosts get mad at us and they turn off our microphones, make sure you fill out a survey while you're going through the process. So so as we're finishing up and get to the next question, make sure you do that. Also, I'm going to steal that question too. I like that it's a coaching aspect. So like Rebecca and Morelli are able to get on a phone call and help people through some things that are sometimes quick and easy. There can be more talk, it can go longer. But I do also think it's accessible. So a lot of people who have that stigma surrounding sitting down and talking to the counseling for an hour, I've done it. It took me a long time to reach out to someone to be like, I don't want to talk to Rebecca for an hour. That's really scary. But having someone call and say, like, basically coach me through this, that was really helpful and really accessible. So I do think it's a great model from that angle.
And that was one big change where we went from a lot of people just coming in for these visits, right? And then now we got encouraged to do a lot more phone reach outs, call them every day, like make small little steps, right? And those minutes build up, but it also makes an impact in how our patients get the care.
There were some growing pains. You go in there as a mental health provider, and it's like, I want that face-to-face. I want that. That's what I want to do. And those are great. And we have patients that thrive on that, and that's what they want, and that's the only thing they want. And then we were realizing that we weren't tapping into the full potential of the program. And, so part of that is, let's reach out. Let's do more phone call outreach. Those folks who aren't coming in or aren't as engaged in person, maybe they do better on phone calls. We realized that was something that we needed to happen, do more. Another thing that we had mentioned, and I just realized, we were also able to offer some groups. And so I do a grief support group, usually about twice a year. We also, with one of our PAs at the office, we developed a chronic pain class, a 2-day class for some of our folks dealing with chronic pain. We were actually able to utilize those contacts during those group settings as part of our collaborative care contacts as well. That was something that I hadn't mentioned before. I wanted to bring that in.
So basically, my understanding is every week, Rebecca and Morelli have a video chat with Dr. Nasra. They review their caseloads, and they particularly pay attention to the patients. You don't spend a lot of time on people who are getting better, right?
Right.
You're like, you're getting better, keep doing what you're doing, right?
Yeah.
But it's the people that are struggling, right? That's where you need that little bit of extra touch. You don't wait 3 months for that, right?
No, absolutely. So the requirement is some face-to-face contact on a weekly basis with the psychiatric consultant. But thanks to COVID, we realized that Zoom is just as effective. So this model allows us to do Zoom or in person, which is great because we are not in the same location. And really what that model is they want you to discuss the patients that are not reaching that 50% improvement in their PHQ-9s and GAD-7. So that slide there where it said it was 40% or so, those are, like Dr. Brett said, 50% improvement. But there's many other folks that have got 2, 3, 4, points improvement in their GAD-7s and PHQ-9s. And we don't want to disqualify that. But collaborative care, that's how they define that significant improvement. So under this model, if we have folks after 3 months have not shown a 50% improvement, those are the folks that we should be discussing with our psychiatric consultant on a regular basis.
Yeah. Can you tell me how many people on your caseload?
On our caseload?
Yeah.
So
it's like 50, 60, right?
So our case, so the idea is we don't want to string people along. So, we could have like, I have 120 people that I try and make contact with. If I don't get those contacts every month, we shouldn't be stringing them along. They should be closed pretty quickly with us because we want to focus on we have found that kind of break-even number is like 60 folks per care manager, billable folks each month. So I feel like, we have the time in our schedules to do more than that, but that's that break-even amount.
How many would that be if your executive director wasn't standing next to you?
That's a very manageable amount, yes.
So 2 questions. One was, how do we use family system groups?
Yep, I can take that.
Bringing in parents and stuff like that. And then the second is the cultural aspect of stuff. So our breakdown in our culture. So I'll let you do family systems.
Yeah, family systems. So that's a great question. So it's not, quote, family therapy, but yes, there are times we bring in that parent. At least very, very minimally, I bring them in initially to describe the program, introduce myself. When we're talking about that population 12 and over, though, those teens, those adolescents, quite frankly, they do better without the parents there. But they have that option. They can bring that parent in. There are times if there's specific conversations that need to be had, if a person needs that support, even some adults who need some some support, having some conversations, yes, that is okay. That is not our traditional, every time I talk to this patient, I'm doing a family session. But we are welcome to bring in the people that they choose for specific situations.
Yeah.
Yes.
Okay, and then Mike, you probably know the data on our population better than I do.
Yeah, so our population in the city of Rochester, 60% of the individuals are black, about 15% are Latino. That gives us about 20% white, and then the rest are other. So we have an increasing population of refugee individuals, both in our city as well as within our clinic. In the last year, we've begun to we do refugee health assessments. Within the first 90 days, someone comes to America, we provide care for them. So that population is growing. I think we do great with interpretation services. We utilize Propio. We do some online training. So the conversations with medical, it's slow, but it works pretty well. But Rebecca, wherever you went, you said it's pretty difficult on the mental health side. So the language barriers can be pretty difficult in order to get through the cultural side with mental health counseling, including this project. So anything else you add to that, so other than it's slow and a little more difficult?
It is slow, it's a little more difficult, but it is not impossible. One of the reasons why having a bilingual counselor on staff who can do Spanish speaking is huge, because that is a large part of our population. I have worked with other languages that are not so common. So, for instance, I had someone who spoke Ukrainian. I had someone who spoke Arabic. The ability to even refer to an outside counselor who speaks those languages, it was almost impossible. We could not find this person, a local therapist who spoke Russian. So using our interpretation services was better than nothing for that patient. So we did do the best we could in those situations.
And with collaborative care, they have to be a patient of our clinic, primary care.
Oh, yeah.
So recently, in the last month, Refugee Resettlement Service of Rochester has reached out to Rebecca and said, we want individuals to be able to come in and receive service from you. So since they're not patients of primary care yet, starting psychotherapy allows us to begin to dive into that more. So we would have a better answer of any more barriers next year. So that's coming up.
So the question was, as far as medication adjustment, who suggests that, who kind of drives that, right? I think we're a team, right? So basically, Rebecca probably doesn't come up and say, I think you should move your bupropion from 150 to 300. She might come up and you say, like, George isn't doing so good. He's tolerating his medication okay, and he's taking it every day. What do you think about increasing it, right? And then I would say, okay, so I would make that a necessary adjustment. And then Dr. Nazra makes a lot of suggestions in the more complicated situations, like you're adding a second agent, or stopping one and starting another one. And we have access to Dr. Nazra. Like I have his cell phone. I can just call him up and be like, yeah. So I think it's sounds like you have some access. I think it's more of working on that collaborative like relationship. That's probably like a next step in that situation. Yeah, and that's the beauty. It's not a specific degree that fills this role, right? There's 4 or 5 degrees that could fill this role, right? Which is a much bigger pool of people to kind of apply, and and if Rebecca moves on to something greater, right? We can replace that a little bit easier than, we can never replace Rebecca. If truth be told.
That is built into the program. Those requirements are in there. Like if you link with your state to do collaborative care, you get a list. These are the only codes that are eligible. Like we don't make that up.
So collaborative care, our codes, our billable codes, are very. We're linked to our state, right? Mm-hmm. And we're billing insurance. So if you don't have insurance involved, you can do whatever you want.
Yeah.
Yeah. Mm-hmm. That's very specific. Yeah. This model, from state down, insurance down, billing code down. That's why we're limited to that, right? So, but if you're not tethered by that,
this could be like a springboard idea for you. Whereas us, we're like, these are our diagnoses, these are the scores, these are your length of time. Right. We're very much in that parameter.
But the reality of mental health is that's like 90% of mental health symptoms, right? And if someone has bipolar or a psychotic disorder, primary care is probably not the greatest place for them to get their mental health care, right? Mm-hmm. Now, it's a great place to kind of connect them to places, but this is really the nuts and bolts of like life for most people when it comes to mental health. Yeah.
We have one question left, if that.
Okay.
Rebecca, if you want to reach out to Rebecca loves emails. She's the director of behavioral health. Our Wedgewood at hisbranches.org. She'd be glad to help you reach out to anything.
I do not love email. Don't email me.
No,
Yeah.
he does not respond.
Call
He
me.
doesn't even
I'm
read
old.
emails from his best friend, so
No.
it won't work. So if
Text
he
me.
has questions for Brad, we could ask him to us, and we'll
I'll
make sure.
filter it for you if you need a question.
That's right.
Dr. Brad, let me know.
And we're happy to talk afterwards as well. But we have one more question, or we good?
We're probably out of
All
time,
right.
so.
The question was, can you split time in collaborative care and do social work, like traditional social work, right? All right.
Sorry.
Yeah.
I agree 100%. It is really challenging, and there's actually a lot of articles doing that research for us that you can even cite showing. Dr. Nauser from day one had said, when I started looking to expand the program and hire another staff, he said, you can do it, but this is why I say no. And he was able to really show that data saying that this is not great. And the, retaining staff under that model is really hard. Your burnout rate is a lot higher when you're carrying that.
Yeah, and I would say in medicine in general, we're moving from like I as a primary care doctor take care of everything to these team-based models, right? So just the general trend is these team-based models. And so learning how to work collaboratively within a team is a core skill in the mental health and just physical health world. And along with that comes division of labor, right? So I want Brittany, our care manager, to help get this person transportation and figure out their housing situation. And I want Rebecca kind of do what you do best, right? Because you're going to be more effective in that role. I'm best as a family doctor because that's what I'm trained for, right? I'm not best as a counselor. I have no clue how to do counseling, right? I can identify people, I can prescribe medications, but I can't do what Rebecca does. And so I let Rebecca do what she does best, right? But we talk all the time. So I think we'll figure it out with the team. Phoebe.
We'll do what we can to share it. Otherwise, Rebecca, if we email Rebecca, we'll make sure we get it to you. So if you reach out to us,
Yeah.
we'll get
If you
it out.
reach out to me directly, I can send you the PowerPoints.
Find me afterwards. I can email it. We'll make sure we get it out.
Yeah. And just recording will be available. Awesome. Thank you so much for coming in. Just a great turnout, and hopefully you guys learned something. And if you guys have any further questions, let us know.
Thank you, guys.